Hello, everybody. On behalf of Pinchin, I'd like to welcome you all to our COVID-19 Building Reoccupancy Seminar. My name is John Holland. I'm the Chief Development Officer at Pinchin, and I'll be moderating today's session and calling in from White Rock, BC. Next slide, please, Kaylee. A few notes. This is a Zoom call, as you all know. So we have a few functions that you should be aware of. First of all, chat, which only use this function, please, if you're having a hard time with technical difficulties or a question about Zoom. Could I ask everyone to raise their hand? It'll help know that we're being heard, that the volume's working okay. And I'll assume that's happening. And finally, we have a Q&A button also at the bottom of the screen. And the Q&A is where you can ask questions that'll be moderated. And we'll attempt to answer as many questions as we can at the end to get this complete. Thank you very much. So next slide, please, Kaylee. So, COVID-19, today and the future. As we speak, some of our provinces have announced plans to start relaxing restrictions as early as next week, so we believe this topic is quite timely. We've assembled a panel of 3 speakers who will be sharing their thoughts and insights on our collective journey to reoccupancy through the COVID-19 period. This is a new and emerging subject for all of us, and we hope that our insights will help move you forward diligently and strategically as we deal with this. Today's presentation is a medical risk-based approach to reoccupancy of buildings. Much of the published guidance from public health so far has been generic, understandably, and we're going to try and build on that guidance in our presentation and try to give some more specific risk-based direction for practical application in buildings as they deal with the issues that you all will be. At Pinchin, through our practice teams, we are continually reviewing published policy and science to attempt to distill diligent and practical solutions for our clients and for our community. We've been doing this process for many years, and it's how we try and stay ahead of the curve and keep our clients appraised with what's current. This presentation on COVID-19 building reoccupancy covers our current knowledge through the combined lens of medical science, risk assessment, and indoor environmental management. Clearly, this is a moving target, but we intend updating our community as we gain more knowledge and as we move through this journey together. And next slide, please, Kaylee. So we have 3 speakers today who I'd like to introduce. The first speaker will be Dr. Michael Schweigert, presenting from Toronto. Michael is an occupational medicine specialist, and he will cover medical and human health aspects of COVID-19. Michael's special areas of interest include occupational medicine, wellness, screening and disability management, quality assurance, and service process design. Dr. Schweigert actively applies information technology to facilitate the delivery and decision-making process in healthcare and population health monitoring. Michael also provides medical health support to several organizations, including Ontario Power Generation, Toronto Police Service, Procter & Gamble, Mount Sinai Hospital, and Sun Life. Michael has also participated professionally on several medical committees on occupational and environmental medicine, and he's the founding president of the Occupational Medicine Specialists Society of Canada. Following Michael will be Dr. Teresa Phillips, presenting from Brampton. Teresa has worked on risk assessment for 20 years on projects and products in Canada and the US. She has experience in toxicology, genetics, biochemistry, and cancer research. Teresa will discuss risk assessment and risk management related to COVID-19. Teresa is a national practice lead of our risk assessment team at Pinchin, and she's based in our Mississauga office. And following Teresa's presentation, Steve Booth, presenting from Bolton, Ontario. Steve will present an outline of technical aspects of COVID-19 risk management in buildings. Now, Steve has more than 20 years experience in infection control and indoor air quality. He previously worked with SARS, Norwalk virus, and also many significant fire and flood damaged building restorations across Canada. Steve has a diploma in architectural technology, and he's also developed standards for mold assessment and remediation and indoor air quality in Ontario through his work with the Environmental Abatement Council of Ontario. Steve is the director of our indoor air quality and OHS team based in Mississauga, Ontario. So as government policy and response and science around COVID-19 evolves over the coming months, as we expect it to, our buildings and how we occupy them will be fundamental to our adaptation and our ultimate return to pre-pandemic activity. It's our hope that today's presentations will help guide all of us in that journey safely and diligently. So with that, I will hand the microphone to Michael to begin our presentations, and I'll loop back at the end. Thank you.
Hello, thank you, John, for that kind introduction, and good afternoon, everyone. I would like to share today a few minutes with you in terms of my experience dealing with employers in the Greater Toronto Area and their response and our experience with regards to the COVID-19 pandemic. Next slide, please. So what I'd like to do is just highlight my experience with regards to the lessons we've learned from dealing with this occupational related aspect of a otherwise community acquired illness, the current state of what we know about the pandemic, as well as some misconceptions, and really talk about the difference between public health direction for the general public versus specific individuals. In regards to the lessons from the occupational aspect of this disease, I would suggest that the one thing that I've personally experienced is the difference between what risks are perceived versus what the real risks are. And I know there are, with regards to the management, they have to deal with the reality of what risks are being experienced or what real risks exist. From the workforce and from customers' perspective, often it comes down to perceptions of risk at the workplace. So things such as symptoms at work that are not otherwise thought to be COVID, screening strategies to allay people's concerns about the workplace not being safe. So we have screening programs to deal with questionnaires and temperature monitoring equipment. And this provides an assurance to the workforce that active steps are being taken to provide for their safety, and really visible evidence of keeping the workplace safe. So such things as being able to actually see the cleaners cleaning touch points regularly throughout the day versus perhaps having them come in at night when they might otherwise typically do so. The state of the knowledge is that we know that COVID is a community acquired condition. And so while it is, of course, an issue for the workplace, the issue doesn't go away when people leave work, and people have to be mindful of the fact that that workplace does not necessarily have to represent a greater risk than the general community with respect to being at work. Social distancing and hygiene are still paramount strategies for dealing with this condition, and when those are not available, particularly with regards to social distancing, appropriate personal protective equipment is the strategy to address the spread of the illness. And symptoms, I think we've all are familiar with the fact that if someone's symptomatic, particularly if they're coughing or they don't feel well, we don't want them at work, even if they perhaps have had a test, which one of the tests to indicate that that they're not COVID positive. And finally, with regards to public health, public health has responsibility for giving direction to the community, but they're also involved in giving direction to specific individuals. They're not necessarily giving direction to organizations as specifically how to manage providing essential services during the pandemic. Next slide. So the question is, what medical changes do we anticipate in the future, and how could it impact building occupancy? Well, there's some much talked about strategies with respect to antibody testing. This is as yet not a actively pursued method of, in this part of the world in any case, of screening people to see who's been previously exposed to the virus. That's the intent of the antibody testing. And the thought is that perhaps if we test for antibodies, we can identify people who have some degree of immunity to the virus. To date, we don't know if that's going to actually be borne out. So it has to be considered with some consideration that the expectations have to be managed as to how effective that will be. Therapeutic treatment and vaccines. Well, these two are much talked about in the media as to being the sort of the solution to our problems to get us out of this prolonged period of the pandemic, which could be 18 months. And we know that it's becoming apparent that large crowds will be an issue for public health authorities, at least for the next year. The treatments and the vaccines to date it's undetermined when these will be available. And so while we're hopeful, they don't necessarily provide any reasonable expectation of being available soon. Next slide. I touched on in terms of the managing risk perception. So the screening for occupants, the temperature screening, and there are handheld devices as shown in the slide. There's also large expensive machines that can screen people from a distance. That addresses people trying to keep people out of the workplace with fever, and as well the health questionnaires. And the health questionnaires can be either online or posted on a bulletin board. Not too often are they given out for people to fill out by hand because of course that would risk spreading the virus. And really the question has always been, how effective are these screening technologies? Well, it's not clear that they're tremendously effective, but certainly they bring peace of mind to the occupants in that building. Next slide. And in thinking about the reality of the current pandemic is that the risk will never be zero. It's a community-acquired illness, and workplaces need to not only do the best they can to make sure that the workplace is safe, but they need to be clear in demonstrating that they are doing the best that they can so people can feel assured that as much as possible, everything is being done. I think that's really important, that people inside the building can see the steps that are being taken to make the workplace safe. Next slide. And that's it for me. Thank you.
Thank you, Michael. I'm Teresa Phillips. I'm the National Practice Leader at Pynchon. And I'd like to begin by reiterating what Dr. Schweigert pointed out, which is that the risk of contracting COVID-19 may never be completely eliminated. So I'm going to talk today about how to assess the risk in a more practical way so that we can all go back to work, but do so safely, because I understand that's what everyone would like to see. And talk about how to assess those risks and formulate a plan to manage them while still reopening businesses and buildings. Before I get started, we have our first poll. Next slide, please. We have our first poll for you, and we would really like to know from our listeners what you think your occupants' biggest concerns about reoccupancy of a building would be. So if you don't mind, please vote using your options on your screen. The options are, do you think the biggest concern would be infection risk, changes in productivity, costs of implementing solutions, buy-in on the effectiveness of controls, or do you have other ideas about that? And our results show that most people believe that their occupants' biggest concern, this is an overwhelming majority, would be the potential infection risk. So I guess we know what's on everybody's mind. Next slide, please. Well, these are unprecedented times. Certainly, I don't need to tell you, but this is something new that everyone is dealing with, and we don't know a lot about the virus right now, and we're learning every day. As our governments plan for restarting the economy and reoccupying buildings and starting businesses back up, we really don't have any formal guidance. We have a matrix of regulations across the country, but really what they're focusing on is the step-by-step process by which they'll allow businesses to resume their activities without any specifics as to how to safely do that. This is uncharted territory in that we don't really have a test for live virus on surfaces, or else we would just clean things and screen for virus. I know you've probably heard about the testing for ribosomal RNA. RNA test is sort of the same thing as doing a DNA fingerprint test. It can detect the genetic material from the virus if it was present on a surface, but it doesn't really tell us if the virus is viable, so it doesn't tell us if it's alive and can reinfect people. As you know, a DNA fingerprint detects when someone was has touched an object, but that person could be long gone and you can still find their DNA on the object. So it's evolving science as well. We're constantly learning and things are constantly changing. So in light of that, how do you know that you've taken all reasonable precautions to reopen your building, let your tenants back in, let the public back in, or your employees? And how do you demonstrate due diligence if you need to do so? Next slide. We think that a re-occupancy plan should follow a risk assessment framework because a risk assessment can inform as to what management measures to implement and also help you communicate those management measures to all the stakeholders. So what it does is it would document everything that you look at, your management solutions, and then give you something to talk to your tenants, employees, and the public about. Next slide. We all do risk assessments every day. You may not realize it, but at pretty much every activity you partake in, you've done a mental risk assessment. One super good example of this would be participating in a contact sport, or for that matter, any sport. Any athletic activity you take part in has the potential for you to be injured. But you probably do a mental, without even realizing it, a mental assessment of the risk and decide that the benefits, whether it's physical fitness or socialization or just the fact that it's so much fun, outweigh the potential risks, particularly because if you are injured during a physical activity, there's a high likelihood that you will recover. We also make decisions in everyday life. Maybe if you're jaywalking, you're doing a risk assessment in your head because you're looking at oncoming traffic and you're doing a judgment call as to whether you can get across the street before that car comes. Even if you cross the street with a green light, there's always a slight risk that a car runs a red, and you're doing that mental assessment and watching your back, making sure you're safe, and that's your mitigation measure. Speed limits are based on a risk assessment that looks at the extent of injury to a human body if it's hit by a vehicle at a certain speed. And speed limits are set in school zones, for example, because as a lower speed to protect more vulnerable individuals, being children. And of course, a super great example of risk assessment is when you invest your money. So everyone knows that if you invest money, there's a potential for loss, but you do a bit of a mental risk assessment and decide that the potential for gains outweighs the potential for loss. And so you're willing to take that chance. And of course, if you invest in RSPs, you know that you will be classified as whether you're a high risk or a low risk individual, and your investments are placed accordingly. So we do it every day. But when it's a professional, an exercise done professionally, and it affects other people, or it affects the public, we believe that it should be a documented procedure and should be done in a really organized fashion in a way that demonstrates that you followed somewhat of a framework. The framework for risk assessment is universal no matter where you go, and it involves a problem formulation where you look at what the potential risks may be, hazard identification, in this case the hazard is COVID-19, risk characterization, and then risk management. The risk assessment framework is used in a variety of situations worldwide, and it's used by regulators for on municipal levels, provincial, national, on all levels to set policies, guidelines, and standards. One key example is that Health Canada did at the very beginning of the COVID-19 pandemic post on their website a risk assessment process for workplaces to decide whether they should close. So we know that Health Canada endorses this approach. Risk assessments are done to create emergency preparedness plans, to approve pesticides and drugs, and various other purposes. At Pension, we have experience doing risk assessments for Legionella and mechanical systems under the Public Works and Services Canada guidance. And I myself do risk assessments every day under Ontario Regulation 15304, which is the Ontario guidance for development of brownfields, so properties contaminated with soil and groundwater contaminants. It doesn't matter what you're evaluating, the process or framework is the same. Next slide. So why is risk assessment the right tool for reoccupancy? We have some really good reasons here that you can consider. The first is that it helps you identify all risk factors. So it makes sure that you don't miss anything. It creates a sort of a document that organizes all the thoughts instead of having them bounce around in your head. It allows you to document that decision-making process, which then allows you to prioritize your management measures. And in doing so, you will likely be able to balance costs versus benefits. So it makes sure that you're not necessarily doing duplicating management measures or spending money on something where there's a suitable alternative. In addition to that, as I said on my previous slide, we believe that Health Canada and various other regulators would endorse this approach. So it would entail adopting a defensible framework. And it also would alleviate occupant concerns, because what it does is it gives you something tangible that you can use to aid in your communication, put people's minds at risk, and demonstrate transparency. Next slide. A risk assessment for building reoccupancy, for example, would look something like this. It would start, since we know that the restart will likely be done in a stepwise fashion though, it's presented as sort of a cycle where you might want to revise and update continuously. But at the very beginning, we would start with a building reconnaissance or an interview with your building managers, company owners, and tenants, and find out what activities and occupants are being reintroduced to that building. We would identify hazards and risks associated with those activities and occupants. And if none are identified, then you can go straight to reopening. But if we do identify potential risks associated with exposure to COVID-19, we would help weight those risks and prioritize, and then recommend a risk management plan, which would then be implemented. Now, as we know, the science is continuously evolving, and so you definitely would want to revise and update a risk assessment, or if you plan to reoccupy the business in a stepwise fashion, every time you reintroduce more people or new tenants or new activities, this could be updated. Next slide. This table shows examples of some of the risk factors that would be looked at. So on the left-hand side, you see a bunch of categories or risk factors. Occupant health is definitely one. Occupant demographics is another. So age, whether they're elderly, are they immunocompromised? Do they have potential conditions that make them more susceptible to infection? We would also look at things like the building layout and the building use. Do you have classrooms, boardrooms, lunchrooms, bathrooms, and who's using them? The public or just internal staff and that sort of thing. Other things to look at are the HVAC system, occupant activities, whether there's site access by not just the public, but how people get in. Are there elevators, stairwells? You know, how do the doors open? Are they automatic or not? And that sort of thing. And finally, also you might want to consider off-site factors such as if you're looking at just your staff, are they going home to vulnerable individuals at night, or are they exposed to higher risk individuals and then bringing back potential illness to the workplace? So as you can see, there are a lot of elements to consider related to each of these risk factors. And if you consider the whole process as a sort of a filter, at the very top of the filter, you have this complex problem with multiple combinations of occupants and activities. And it could get pretty messy when you think about it. So the risk assessment would help by screening all these combinations and screening out the ones that don't necessarily apply to every building or business activity. Secondly, you could then filter those remaining combinations and take out the ones that are considered low or virtually negligible risk and just focus on the ones that are bigger risks. That would help you prioritize. So the remaining activities would be prioritized and you would decide which ones require management. Finally, at the bottom, you would select the most practical management measures from whatever options are available for each of the higher priority risks. Next slide. And when you get talking about risk management, the hierarchy of risk management controls would be followed. And this is an action list. This helps you take that action list of management measures that you need to implement and address them according to the hierarchy. The hierarchy is a system of determining feasible and effective control measures that's adopted by NIOSH, the CDC, Canada Centre for Occupational Health and Safety, and various other safety institutions. So it's recognizable by all these and other governing bodies and a useful tool for prioritizing management. You'd start, if possible, at the top with the most effective measure, which would be eliminating the hazard. But that may not always be possible because that would entail removing any individual that was a carrier or any potential virus exposure. The second most applicable management measure or effective management measure in the hierarchy is substitution, but that doesn't necessarily apply here. It applies in an industrial setting where there's the use of chemicals that may be toxic, and you have the potential of replacing a toxic chemical with one that's less toxic. So if elimination is not possible and substitution is not possible, then you get to engineering controls, administrative controls, and PPE. The engineering and administrative are controls to isolate people from the hazard, things like plexiglass barriers. Administrative is changing how people work, so physical distancing. And then when neither of those work is PPE as an option. So on that note, I'm going to hand things off to Steve Booth, who will provide a more detailed discussion of how the risk assessment approach would be applied in practice to generate and implement risk management and communication plans, and then what those plans might look like for you. Steve?
Good afternoon, everyone, and thanks, Teresa. So as Teresa introduced, I'm here to talk about sort of the practical side of the risk assessment. So taking the kind of ideas that Teresa's talked about and how do we go through a process in a building, evaluate the hazard, look at the risks, and figure out the solution measures. So we're going to start off with a poll, I think. So Kaylee, can you switch to the next slide? So before we start talking about, what the risks are, let's find out what we think the risks are, what the highest risk is. So is it airborne transmission through the HVAC system? Is it picking the virus up through contaminated touch surfaces, so getting it off the elevator button? Is the biggest risk that you have some underlying health condition? Or is the biggest risk your interaction with other occupants and people in the building? So we'll give everyone a few minutes to log in their results. So about 60% of us, see that interaction with the other occupants in the building is the highest risk, and we can certainly talk to that. And, but there is, I think it's important to note, there's a significant number of people that are looking at airborne transmission through the HVAC as a significant risk. So, Kaylee, we want to move to the next slide. So what I want to focus on here is that sometimes the hazard that we're managing isn't the real risk at all. And right now, people are at home. They're displaced from their usual patterns of living. Stress levels for a lot of people are high, and sometimes the real risk of the contracting the SARS-CoV-2 virus isn't necessarily what we're trying to address. We're trying to make sure that there's a level of comfort and a level of understanding of the procedures amongst the people that are coming into that building. So that requires this really high level of good quality communication. And I think that quality communication needs to start early. It needs to happen often. It needs to be very frank. So it doesn't just need to highlight the things that are going well, but it needs to identify when things don't go as well as you would have liked and discuss how you fix those problems. And it needs to look for feedback from the people, either the employees or the tenants in the building, about how it's going. And I think if we manage that communication well and we keep that dialogue open, we'll have a much greater likelihood of having people reoccupy the building and then continue to reoccupy the building. We've seen numerous occasions, not COVID-19 related, where very, very small hazards and poor communication have resulted in a situation where building tenants or employees are very, very upset and don't want to come back to the building, even though from a hazard point of view, there's no reason to justify that. So it's really important that we focus really critically on the communication and managing that outrage component of the risk. Next slide, Kaylee. So as we start to consider what the hazard is and what the main risks are associated with it, I think the vast majority of this audience looked at the highest risk being that droplet and direct contact risk that comes from our direct interaction with other people. So that's you coming to my office, me coughing, sneezing, or speaking moistly, and those droplets being transmitted from me directly to you in close proximity. That and me coughing on my hand, shaking your hand, and then transmitting the virus to the other individual. The public health agencies internationally recognize that as the single best way to transmit the disease and the virus from one person to another. The next level of risk, sort of the medium risk level, becomes indirect contact. So I don't necessarily touch you directly, but I cough on my hand, I put my hand on my hoteling station desk and on my keyboard and on my mouse. I go home, you come in an hour later, you use the same desk and computer keyboard and mouse that I'm using, and you pick up the virus from the droplets that I've left behind on those surfaces. So those two combined, the World Health Organization says that in China, looking at 79,000 cases of the virus, those two modes of transmission make up 100% of those 79,000 cases. And that's the total number of cases that they examined. Recently in the media, and if you're spending time talking to academics about things like droplet nuclei and how droplet nuclei are created in buildings, which are very, very small particles that can stay airborne for an extremely long time and get transmitted through air handling systems, there has been a concern, at least, that the virus could potentially be airborne and could get transmitted through surfaces. I think it's really important to say that as it stands now, all of the public health guidance is united in that the two things that we have to be concerned with are droplet and indirect, and not this idea of airborne transmission. And frankly, from a building owner and occupier's point of view, if airborne transmission were a really substantial way to transmit this disease, it would be very hard for us to occupy any of these, any buildings again. So if we want to move on to the next slide. So let's have a look at this idea that Teresa introduced of doing some reconnaissance in the building. So let's think about what activities an individual is going to take when they come into their commercial office and see what those potential risk points are. So, the first thing that someone does is they park their car in a parking lot. They may park their car in a parking lot that's busy enough that a parking lot attendant has to, move their car for them to accommodate other people coming and going from the lot because the lot's that full. So, immediately you have a direct contact with the parking lot attendant. You have potential surface transmission via the steering wheel and surfaces in the car and your keys and those kind of situations. A person then enters the lobby and they have contact with other individuals, so there's more direct contact. This person's a bit of a health nut, so they run up the first three sets of stairs, and they're in contact with handrails and people coming down. So there's a whole other layer of risk, and we start to see all these tasks that we previously took as very mundane, now take on a certain level of risk, each and every one of them. You know, and then, you know, from going to your reception area to working at your hoteling station to grabbing that cup of coffee from the kitchenette to using the washroom, we have to look at all of those aspects of what the individual is doing in the office. You want to switch to the next slide? So when we come to retail areas, you know, we have similar conditions, but we have additional considerations as well. So, you know, we may be taking transit into the mall, so that, you know, there may be risks associated with that. We may be accessing the building. So it might, you know, an office building may have one main entrance, but a shopping mall might have 10 different entrances to accommodate people getting in easier. So how are we going to manage physical distancing by limiting the number of people coming in when we have 10 different spots that people are coming in? What do we have to do to manage that access? You know, we have a whole different level of concern in areas like food courts. So we have seating area that we set up to have, you know, 4, 5, or 6 people, or even individuals sitting in very close proximity. We obviously want to limit that, but we may have there may be situations where families come in who are living together and want to sit at a table for 4. So how do we know, you know, who's a group of teenagers that, you know, shouldn't be sitting together, and how do we know, and how do we know who that family is who can sit together? Those are very difficult decisions that, you know, we need to consider as part of the risk assessment and make decisions in advance so that staff in the buildings aren't trying to make decisions on the fly. You know, lending things like strollers, shopping carts, and wheelchairs, that's very common in retail settings. How do we manage the cleanliness of those items? And then how do we protect the salespeople in those settings who are, you know, working directly with the public on an ongoing basis? So do we want to move one slide forward, Kaylee? So we mentioned Teresa mentioned this idea of hierarchy of controls, and really elimination being kind of the ideal control measure. You know, in an ideal world, we could have perfect screening. We could have people self-screen. We could have screening at the entry to the building. We could have screening by the employer, and we could be certain that no one that was infected or no one that was infected with the virus actually came into the workplace. And then we wouldn't need any precautions in our building at all, because we would have eliminated the hazard. I mean, the reality is that that's not going to be possible for us to do. I do think, though, that some level of screening is important to rule out those people, or to try and exclude those people who may, you know, just feel I've got to go into the office this day and work despite my bad cough. You know, those people are still going to be around, and you know, if we can do our best to exclude those. And to go back to Michael's point about the communication, you know, even if it's not 50% effective in the screening, you know, it does demonstrate clearly and right in front of everyone that's coming in that you as building owners and employers are doing something about the problem, and you're doing your best to keep sick individuals outside of the building. So, you know, let's move on from this idea of elimination. The other thing we can eliminate are some of the activities. So when we look through all the activities that we are considering, what we did in either the office building or in the retail center, you know, what activities could we eliminate? So can we prop doors open in offices? So we may have, not fire doors obviously, but we may have had doors for privacy into boardrooms and private offices that now we simply leave open, so that we eliminate the contact with that door handle every time because the door is open. You know, we have a kitchenette space on an occupied floor that has a shared coffee machine, shared cutlery, a shared fridge, various shared items. Like, is it possible just to say, hey guys, for the next 6 months, we're just not going to use that space in that way anymore? So that's another, you know, instead of trying to ramp up and decide some kind of very difficult cleaning schedule and regime, we just say, hey, we're not going to do those things anymore. And then on the retail side, you know, not taking cash, but taking only contactless payments, so debit or credit. So those kind of things are ideas around elimination that can help us reduce our costs and reduce our burden on the cleaning and the PPE side. Can we move to the next slide? So let's consider this, let's consider engineering and administrative controls, and let's think about that highest risk level of transferring the virus, droplet and direct contact with individuals. So, you know, the first thing we can look at are face coverings. So face coverings are not a means of personal protection. The intent there is not to prevent me from inhaling viruses or droplets that you have, that someone else has spread. The idea here is that if it's a physical barrier between my mouth and the office space. So when I cough or sneeze or speak, those droplets are captured at the source and aren't spread elsewhere. So we can certainly look at face coverings. We're obviously going to be looking at reducing occupancy levels, both in offices and retail. And the drawing here on the side is our Pynchon's Calgary office. And sort of our idea, if we tried to maintain that 6-foot spacing and we tried to fill kind of as many desks and offices as we could, we go to a maximum of 50% occupancy. And that 50% occupancy involves reworking boardrooms, lunch and cafeteria areas into workspaces so that people can actually be in the office. I think for many people in the commercial office side of things, elevator logistics are going to be extremely difficult. In many cases, it's not going to be possible to maintain 6 feet, even if people are standing in opposite corners of elevators. So, so even if we introduce face coverings and we allow people to get a little closer, we're still going to really reduce the number of people who are getting up and down through buildings. We've already talked about food court seating a little bit. But the last thing I'll talk about is sort of creating some pedestrian pathways. So, a primary access point to the building, a single exit point to the building so people aren't crossing paths as they come in, and then potentially a circulatory space within the actual office layouts so that, so that people aren't walking past one another. And the other idea here is, that ties in with elevators and how long it might take people to get in, is maybe staggering shifts coming into buildings so that, if you're going to be at 50% occupancy or 30% occupancy in the building, 30% come in at 7 in the morning, 30% at 8, and 30% at 9, or, some variation similar to that. Let's move on to the next slide, Kaylee. So the next level of engineering and administration control we're looking at are the medium risk level of indirect contact, so stuff we pick up from surfaces. And the first and foremost measure there is personal hygiene. So it's not going to be possible for any building owner or employer to keep every surface in every building scrupulously clean at every single point in time. So that's why, no matter how well you're cleaning, you're going to have to still support the occupants and the staff's ability to do personal hygiene. So that'll mean keeping washrooms clean, making sure there's soap available, making sure there's hand sanitizer available, tissues available, potentially replacement face coverings, all the signage, maybe training to support how personal hygiene needs to happen. All of these things need to work together so that we can support the individual in their effort for personal hygiene, because ultimately the health and safety in the building is not just the employer's responsibility. It's not just the building owner's responsibility. It's a combined responsibility for all the people in the building. So what we can do to support personal hygiene is, I think, really important. And then when it comes to cleaning, we really need to be looking at 2 different levels: a proactive level of cleaning and an incident-driven level of cleaning. So there's what do we do before people come back, and I would suggest that it's important to do a good, thorough cleaning beforehand, so that we set a really good base level of clean before people start coming back, and then hopefully it makes it easier to maintain that level of cleanliness going forward. And then, eventually, in somebody's building somewhere, someone's going to come to work and they're going to either get sick at work, or you're going to find out 2 days later that they had COVID-19. And in that case, you're going to have to close those areas and undertake a thorough cleaning of that space. So the scope of those is going to be relatively similar. You're going to cover off the high touch areas. In the incident, you're going to focus primarily on locations where the person was. But the skill level of the cleaner might be slightly different. So certainly the janitorial staff, most people have in their buildings, with a pretty limited amount of additional training, can certainly handle that proactive cleaning. But for the incident level cleaning, I think there's a higher level of PPE required, and we really want to make sure that both the cleaning and the disinfection goes extremely smoothly. So potentially more training or a different group doing those 2 different kinds of cleaning. We're going to want to look at cleaners versus disinfectants. The important thing, and I'll keep it short here, that the disinfectants really should be Health Canada registered disinfectants with a drug identification number. And Health Canada has just in the last few days, they always had a list of approved products, but now they've issued a much larger list with interim approved products. So that should make it much easier for people to select disinfectants that are actually effective against COVID-19. Can we go forward a slide, Kaylee? So, and finally, we look at this sort of low airborne risk. And I think it's a low risk with respect to people actually getting sick that way, but I think it probably measures pretty high on that occupant concern scale. So I think we need to work towards some controls, but I think we want to have those somewhat balance that level of risk. So, one of the ASHRAE recommendations is to install UV lights in HVAC systems, and that, may very well do a good job, but does the high cost of that balance off with the risk that airborne transmission represents? And right now, I'll remind everyone that direct contact and surfaces are the two main modes of transferring the infection to someone else. But on cost-effective HVAC, flushing the building prior to occupancy, running the air handling systems a little longer, increasing ventilation, improving filtration, and not necessarily changing filters or the type of filter, but making sure that the filters you have in the building are operating as well as they can, so there aren't gaps and those kind of things that are allowing air to bypass the filters. Those kind of things can be done ahead of time and can be constantly maintained. So this idea that these very small droplets can occur when we breathe and then float, that's driven a little bit by humidity. So if we maintain humidity well between that 30 to 60% range, that's going to help minimize those risks. And then I think, both for the cleaning and for the ventilation, providing some monitoring that confirms that, yeah, we really are providing additional ventilation, and here's the proof. And on cleaning through ATP or total bacteria samples to say, hey, not only do we say we're cleaning, but look, here's empirical evidence that the cleaning is working and keeping surfaces clean. So we go to the next slide, Kaylee. So just to sort of try and wrap things up so we have some time for questions. I've probably run a little longer than I should have. We believe that this sort of risk-based approach can be based on evidence in medical science. So I think that needs to form the foundation. That this process provides a defensible and diligent and predictable way to manage the hazards, so that we're not racing all over the place responding to everything last minute. By looking at it in this way, unlike having a list of 500 things that you can do, we can make it suitable for each building, and we can identify these are the 50 things that you should do to get you the greatest bang for your dollar, because all of these things are going to cost money to implement, and money or time or effort, and we all have limits on all of those. So we have to find ways to prioritize our actions and really focus our effort where it makes the most difference. And then again, I think we've already said it kind of balances the risk and the cost, whether that's financial costs or our effort costs or energy costs or all those kind of things. We can try and achieve those balances through quality risk assessment. And with that, we'll go to the next slide, which I think is questions, Kaylee.
Okay, thank you, Steve. Thank you, Michael. Thank you, Teresa, for excellent presentations. We do have some questions, quite a few questions from the audience, and I'll go through them one by one at the time we have. First one is on temperature screening, and I'll ask one for Michael. How effective is screening for temperature really when those administering the test may not be medical professionals and people could be asymptomatic and not show a fever? Is this an initiative worth implementing in an office environment, all things considered?
Well, that's a good question. And I think the issue, there's a couple of, parts to that question. In terms of the temperature screening itself, that's a relatively straightforward procedure that people can be trained, the lay people can be trained to perform. I think the question about, there was part of the question about asymptomatics, and those people, obviously, by definition, we don't know that they're currently carrying the virus. We believe that they're not as infective, or cannot spread the illness to the same extent, but it does present a challenge. And I think some of this gets just to the issue of what Teresa and Steve both touched on, which is that really we're demonstrating that we're doing the best we can to make the workplace as safe as possible.
Okay, thank you, Michael. Steve, question for you, I think, regarding UV testing. Actually, one on humidity. Let's go to humidity. What are the benefits of humidity control, i.e. the virus is not killed off unless at 30 degrees Celsius and 80% relative humidity?
Yeah, so the idea of maintaining, relatively within a certain range isn't about killing off the virus. So like, I don't think we're going to have buildings in that range. It's not going to be comfortable to people to work in. But what we can do is, we know that 30 to 60% range puts an individual's airways in a good condition, so that that's a good zone for us to be in and to be healthy. So us being there and being healthy, may provide some protection. It also, in that range, when it gets particularly dry in buildings, that's where these larger droplets can potentially evaporate. So that a large moist droplet is emitted, it evaporates in the air and becomes this thing called a droplet nuclei, and then those droplet nuclei can hang in the air for an extended period. So avoiding those very, very dry conditions helps us avoid that occurrence, and maintaining relatively in that 30% range sort of makes the best conditions for us in the building.
Okay. Thank you, Steve. I think a question for you as well, and I'm going to just give you one more. It's regarding cleaning. So it says, for cleaning and disinfection, what is the verification point? I guess the question is, how do we verify adequate cleaning and disinfection?
So there are really two methods being used now. You can do total bacteria samples. So what we've seen in buildings is post a cleanup, if people have cleaned well and disinfected well, there's none to almost no bacteria in a surface. And what we have seen in buildings that have been well cleaned, but where our testing happened, a day later, and people had been back in the building touching surfaces, is those bacteria counts, rapidly begin to climb again. So that kind of bacteria testing can be useful to demonstrate that you've done a good job of cleaning and disinfecting. It doesn't detect the virus. That's not the point. The point is just to demonstrate that you've cleaned the surface well and you've disinfected well. So the normal microbiology that's on the surface of your desk or keyboard or elevator button has been eliminated or mostly eliminated. That demonstrates good cleanliness. The other way to do it is through an ATP meter. So there are a number of different commercial brands at ATP, and there's very good evidence that demonstrates that low levels of ATP correlate very well with very well cleaned surfaces. So either of those two methods, the ATP has the advantage of being able to be done on site with immediate turnaround, whereas the swab samples have to get sent to a lab. So there are pros and cons to both.
Okay, thank you, Steve. Teresa, a question for you regarding risk assessment, a generic question. You've had a long experience with risk assessment in many domains, both environmental and in product testing, I think, and medical. Are there any examples of where risk assessment's been a particularly useful tool and has given a high level of societal safety or performance?
Well, certainly, I know that it's a widely accepted approach for things like pesticide approvals, drug approvals, setting regulations. My experience has predominantly been in environmental work, but there are supporting documents for the work that I do that are coming from the medical realm as well. So I think in any decision-making process that our governments partake in, there's some form of risk assessment being undertaken that supports the decision-making process.
Right. Okay. Thank you, Teresa. I think a question back for you, Steve, is on. We had a couple on this on cleaning protocols. Comments on ionization versus UV in controlling airborne contaminants or cleaning surfaces, I guess.
Yeah, I mean, so our focus has really been on quality cleaning. So, physical removal of dirt with wipes and soap and water, and then application on those surfaces that you're going to be in contact with an approved disinfectant product with a Health Canada drug identification number. I'm not saying it's not feasible that some of those newer technologies might provide some success, but I think what we know works is wipe the desk, clean it well, and then apply a disinfectant. If the others work or don't, I don't think there's kind of good peer-reviewed data on a lot of that as it stands. I mean, there's certainly some evidence on UV light. So in a hospital or healthcare setting, UV light can be effective for airborne viruses where you're disinfecting the upper portion of the room, and was successfully used for tuberculosis. But I think we also have to look at that and say, hey, what are the risk vectors of this transmission of this virus? It's large droplets that settle out quickly on the surfaces or get transmitted directly from me to you, not airborne transmission of the virus. So, doing something to control, spending a lot of money to control airborne transmission when that isn't seen as a significant risk, I don't know that that's a place where I would put my effort and energy.
Good, thank you. Question for Michael. There's been lab testing on method viruses and aerosols float and stay in a room of 10 people for at least 20 minutes. How confident are we that airborne is not such an issue? And I guess the inferred question is, do droplets stay suspended for a long period of time? And should we be more cautious about social distancing than we're being advised?
So that's a great question, and the science is still evolving with that. And the trouble is that, or the challenge is that this is a novel question for us as a society. And so there is a lot of scrutiny underway regarding airborne transmission. We do see some studies that suggest it's more of a problem than we know, although the bulk of the evidence still seems to be leaning towards the droplets as the issue. And these typically don't stay airborne for a period of time that would define them as being an airborne condition. There are some hospital procedures such as intubation where we believe that there is more of an airborne component, but in terms of practices right now, the focus is on the droplet transmission.
Okay, good, thank you. And really one more for you, I think, Michael. I can't get to all the questions. We're running out of time. This will be our last question, I think, given the time, but it says that COVID particles are said to be 1 micron, and being so small can piggyback on other particles, I guess they mean airborne particles. Would this not make airborne and therefore a mechanical concern? I guess the potential that other particles travel further. Would the COVID-19 potentially hook onto the other particles in a building?
Yeah, and I know that there's been some recent studies that suggest that the virus can hook on to pollution particles in the air. So, I mean, it does get to the question as to how does that translate into practice and in terms of application for an office environment, for example. And I'm not certain that we have great answers for that. But I mean, these are relevant questions. We just don't have the science that can rigorously support yes or no in either direction.
Okay, thank you. And I think your last point ends very nicely, Michael. This is, as I said in my presentation, this is a journey. We're going to continue researching this and providing, as well as we can, appropriate solutions for our clients that minimize their risk and maximize practicality with, of course, with medical support. We do intend continuing to present seminars like this as issues evolve. So stay tuned for future seminars. I would like to thank all my panelists and the helpers that helped put this together at Pynchon. It's been a team effort and it's been really, really appreciated. You, the audience, thank you for attending, taking out an hour out of your day and an hour out of what seems like an endless daily stream of coronavirus presentations. And you will get a questionnaire with feedback. And that feedback, if you could make suggestions on future things you'd like to hear, we'll try and present that as well as we can. So with that, I'd like to thank everybody. Have a good, safe day. And we'll talk to you all soon. Thank you very much. Signing off.